Dear students, today we are going to discuss the very important topic, and this is the lupus nephritis. If we talk about the lupus nephritis, in 50% of the SLE patients, the lupus nephritis is involved. So in SLE patients, basically the 50% of the patients are involved as a lupus nephritis, and this is the most important predictor of the death. This lupus nephritis is the most important predictor of the death. SLICC included lupus nephritis as a standalone diagnostic criteria for SLE. So SLICC included lupus nephritis as a standalone diagnostic criteria for the SLE. So if we talk about the lupus nephritis, and if we talk about the pathogenesis of the lupus nephritis is basically caused by some risk genes and maybe some environmental factors. The lupus nephritis may be caused by some risk genes and some environmental factors, and these environmental factors may be the drugs, maybe the infection, maybe the hormones, and maybe the UV light. Actually what happens if we talk about the pathogenesis, the cell death occurs. If there is the cell death, so there will be the delay in dead cell clearance. So there will be the delay in dead cell clearance and activation. Because of the delay, there is activation of the viral recognition receptors. Viral recognition receptors on innate immune system. Viral recognition receptors on innate immunity system cells. And what does it? It does the activation of the autoreactive B and T cells. So what happens if we talk about the pathogenesis? So some risk genes are involved in the pathogenesis of the disease, and beside this risk genes, some environmental factors are responsible. These environmental factors are maybe the infection, maybe the hormones, maybe the ultraviolet light, or maybe some drugs are responsible for these environmental factors. Once the cell death occurs, so there will be the delay in dead cell clearance. So if there is the delay in dead cell clearance, the viral receptors of innate immunity cells are activated, and because of the activation, what happens? The activation of the B and T cells. Now, beside this, there may be the non-specific trapping of circulating immunocomplexes. There may be the non-specific trapping of the circulating immunocomplexes. Basically, immunocomplexes are formed some extra places, and these are trapped in the glomerulus, and there may be the in situ formation of the immunocomplexes. So if we talk about the immunocomplexes can be either trapped, or immunocomplexes can form in situ by interaction of the negatively charged components of the glomerular capillary wall. So what happens? These in situ formation of the immunocomplexes, how does it form? Because of the negatively charged glomerular capillary wall, some immunocomplexes are formed in situ, and another mechanism is immunocomplexes are formed outside of the glomerulus, and they are trapped into the capillary walls. So this is the pathogenesis in respect of the immunocomplex formation. Now what happens? Because of the deposition of the immunocomplexes, there is the complement activation. So when these immunocomplexes are deposited, there is the activation of the inflammatory cascade. So this is the pathogenesis which we are discussing. Now what happens if we find the thrombotic microangiopathy with this lupus nephritis? This may be associated with the antiphospholipid antibody and can worsen the prognosis. So if we found the thrombotic microangiopathy with anti-phospholipid antibody, then it can worsen the prognosis. If we find the lupus podocytopathy, so in a lupus podocytopathy is basically associated with heavy proteinuria, and but there is not found the inflammation, or there is not found the inflammatory cascade reaction, or there may be not found the interstitial or vascular lesion. So we usually found only the podocytopathy and with heavy proteinuria. So there may be the lupus nephritis, and lupus nephritis may be associated with podocytopathy only. Lupus nephritis may be associated with thrombotic microangiopathy with anti-phospholipid antibody, may present or may not present. So we are discussing the pathogenesis of the lupus nephritis. In respect of the pathogenesis of the lupus nephritis, basically some risk genes are involved in the disease and some environmental factors are responsible for the disease. Once cell death occurs, there is delay in the clearance of the cells. Once there is delay in the clearance of the cells, the viral recognition receptors are activated in innate immunity system, and there is activation of the B and T cells. Besides this, some immunocomplexes, circulating immunocomplexes are trapped, and or it may form in situ formation of the immunocomplexes, and they are interacted with the negatively charged components of the glomerular capillary wall, and what happens, these complements are activated and inflammatory process occurs. So this is the pathogenesis in brief about the lupus nephritis. Now what are the clinical features? How the patient present? The clinical feature in lupus nephritis may be the variable. The clinical feature in lupus nephritis may be variable. The patient may be asymptomatic, and the patient may present with proteinuria, nephrotic syndrome, and patient may present with the rapidly progressive glomerulonephritis. The patient may present with the hematuria, proteinuria, patient may present with the nephrotic syndrome, and the patient may present with the rapidly progressive glomerulonephritis. So the presentation is variable. Now what we do, what investigation, or how do we do the workup? When we talk about the workup, we usually find the high ESR, high CRP. We find usually the anti-dsDNA positive, antinuclear antibody NA is found positive, complements are usually low, CH50 low, C3, C4 are usually found low. And because beside this, if we do the anti-phospholipid antibody test, so usually these may be present or may not present. So basically what happens, the labs usually do not correlate with the disease. Labs usually do not correlate with the disease. It doesn't mean that if the labs are negative, then there is no lupus nephritis. So usually labs do not correlate with the disease. So we are supposed to do the biopsy. We are supposed to do the renal biopsy, and the renal biopsy is very important. Number one, for the diagnosis, and number two, to decide the class of the disease. So renal biopsy is very important to decide the for the biopsy and to decide the class of the disease. So biopsy is necessary. Now this is about the pathogenesis. Now we talk about the pathology. When we talk about the pathology of the disease, so usually IgG dominant full house pattern is found. IgG dominant full house pattern is found. So there may be IgA, there may be IgM, and there may be the complements like C3 and C1q deposition, and full house pattern is usually found. So if we do the immunofluorescence, there is found the full house pattern, and there is the glomerular stain for the glomerular stain for the IgA, IgM, IgG. There will be the deposition of the C3 and C1q. Dominance may be there. So this is called the full house pattern. So full house pattern is the characteristic of the lupus nephritis. If we see the electron microscopy, when we see the electron microscopy, there is found usually the endothelial tubulo-reticular inclusions. Endothelial tubulo-reticular inclusions. There may be found the subendothelial and subepithelial deposits. So when we see the electron microscopy, there is found the subendothelial and subepithelial electron dense deposits or deposits. And there may be found that endothelial tubulo-reticular inclusions. Extraglomerular immune deposits within tubular basement membrane, interstitium and blood vessel may be found. Extraglomerular means not in glomerulus, other than the part of the glomerulus, like tubules, like interstitium, tubular basement membrane, interstitium and blood vessels. There may be found the immune deposits. So we have discussed the pathology, and in biopsy what we find usually the IgG dominant full house pattern. We usually found the endothelial tubulo-reticular inclusion in electron microscopy. We usually find the subepithelial and subendothelial deposits. We usually found the extraglomerular immune deposits in tubular basement membrane, interstitium and blood vessels. So we have discussed the pathology. So after discussing the pathology, pathogenesis, we are now going to discuss the classification of the lupus nephritis. We are going to discuss the classification of lupus nephritis as per the International Society of the Nephrology and RPS. So if we discuss the classification, the first we classify the lupus nephritis as a class 1, and the class 1 is the minimal mesangial. Class 1 is the minimal mesangial. When we discuss or when we describe the classification of the lupus nephritis, the number 1 is the minimal mesangial. Class 1 is the minimal mesangial. What does mean? The minimal mesangial means mesangial immune deposition only on immunofluorescence and electron microscopy are usually found. Some mesangial immune deposition are found. On light microscopy, there are no any changes seen. So this is called the minimal mesangial or class 1. So when we describe the classification of the lupus nephritis, the first class is the minimal mesangial. The second class is the mesangial proliferative lupus nephritis. When we talk about the mesangial proliferative lupus nephritis, the mesangial hypercellularity with immune deposition are found. When we talk about the mesangial proliferative lupus nephritis, so there is found the mesangial hypercellularity with immune deposition. Now we come to the class 3. Class 3 is the focal lupus nephritis. Class 3 is the focal lupus nephritis when inflammatory injury or inflammatory process involves less than 50% of the glomeruli. When this inflammatory process involves less than 50% of the glomeruli with crescents, with fibroid necrosis, with subendothelial immunodeposition, then we call it the focal lupus nephritis. So we are discussing the class 3, and the class 3 is named the focal lupus nephritis. And the focal nephritis when inflammatory process involves less than 50% of the glomeruli. When it involves less than 50% of the glomeruli, the features like crescents, like fibroid necrosis, like subendothelial immune deposition, these are usually found. These are called focal lupus nephritis, and this is the class 3. So when we discuss about the class 3 lupus nephritis, we can divide it into A and C. A means acute lesions, C is chronic lesions. So class 3 is further subdivided into acute lesions and chronic lesions. When there is usually proliferation and necrosis, then it is called the active lesion. When there is sclerosis and fibrosis, this is called the chronic lesion. So when we divide the focal lupus nephritis or class 3 lupus nephritis, this is divided into A, active lesions, and C, chronic lesions. Active lesions when there is proliferation and necrosis. Chronic lesions when there is only sclerosis and fibrosis. Besides this, A third subdivision or third part is also called A oblique C, means the features of active and chronic lesions are also found, then we called it A oblique C. So what is A oblique C? A oblique C means the features are found of active lesions and the features are found of chronic lesions. So we are discussing the classification as per International Society of the Nephrology, and we have discussed the minimal mesangial, number 1, class 1. We have discussed the class 2, that is called the mesangial proliferative, and we have discussed now the focal lupus nephritis, which is called the class 3. Class 3 focal lupus nephritis is further divided into A, C and A oblique C. A means acute lesions, C means chronic lesions, A oblique C means both features of acute and chronic lesions. And what are the features of the acute and chronic lesions? In acute lesions, there may be found out the proliferation and necrosis, and in chronic lesions there will be sclerosis and fibrosis. So this is the focal lupus nephritis. The fourth one is the diffuse lupus nephritis. The fourth one is the diffuse nephritis. Fourth one means the class 4 is called the diffuse lupus nephritis if the inflammatory injury is in more than 50% of the glomeruli. If the inflammatory injury is in more than 50% of the glomeruli, then we call it diffuse lupus nephritis. And again, they can be subdivided into A, active lesions, C, chronic lesions, and A oblique C means mixed picture. So diffuse lupus nephritis can be further divided into acute lesions, chronic lesions, and acute oblique chronic lesions. And further we can we can divide into segmental or globular. Segmental, or if a particular segment of the glomerulus is involved, then it is called the segmental. If there is a whole glomerulus is involved, then it is called the globular. So this is the diffuse lupus nephritis. So we are discussing the classification of the lupus nephritis, and we have discussed the minimal mesangial class 1, we have discussed the mesangial proliferative class 2, we have discussed the focal lupus nephritis class 3, we have discussed the class 4 lupus nephritis, which we call diffuse lupus nephritis, and now the fifth comes the membranous lupus nephritis, which we call it class 5. Class 5 means membranous lupus nephritis. Now what happens? When there is a glomerular capillary thickening on light microscopy, if we see on the light microscopy, there is glomerular capillary thickening with subepithelial immune deposit on electron microscopic or immunofluorescence. So when we discuss about the membranous lupus nephritis, in membranous lupus nephritis, if we see in light microscope, there is glomerular capillary thickening. And on electron microscopy, there is subepithelial immune deposition. Subepithelial immune deposition in electron microscopy oblique immunofluorescence. So this is the fifth class, and the fifth class is the membranous lupus nephritis. Now after discussion of the fifth class, now we come to the last class, and this is called the sixth class, and this is called the advanced sclerosing lupus nephritis. So when we discuss about the advanced sclerosing lupus nephritis, more than 90% of the glomerular sclerosis is found. So this is the class 6. So in respect of the classification of the lupus nephritis, we are following the classification as per the International Society of the Nephrology. So as per International Society of the Nephrology, the class 1 is the minimal mesangial. Minimal mesangial means mesangial immunodeposition only found in immunofluorescence or electron microscopy, and there are no other changes. So these are called the minimal mesangial. Mesangial proliferative means there is mesangial hypercellularity. With immune deposition. So we call it mesangial proliferative. When we discuss about the focal lupus nephritis, inflammatory injury is less than 50% of the glomeruli, with crescents formation in the glomerulus, with there is febrile necrosis, and beside this there may be the subendothelial immune deposition, and it is further divided into acute lesions and chronic lesions and acute oblique chronic lesions. In acute lesions, usually we found the proliferation and necrosis. In chronic lesions, we usually found the sclerosis and fibrosis. In acute oblique chronic lesions, we usually find the features of both of these. In class 4, which we call this diffuse lupus nephritis, and diffuse lupus nephritis, usually more than 50% of the glomeruli are involved, and there is inflammatory injury more than 50% of the glomeruli. And it is further can be subdivided into acute lesions, chronic lesions, and acute oblique chronic lesions, as we described before. Now this is further subdivided into segmental or global. After the class 4, we come to the class 5, and in class 5 lupus nephritis, which we call the membranous lupus nephritis. Membranous lupus nephritis, basically there is glomerular capillary thickening on light microscopy, but when we see in the electron microscopy and in immunofluorescence, there is subepithelial immune deposition. So this is called the membranous lupus nephritis. When we call the advanced sclerosis disease or advanced sclerosis lupus nephritis, more than 90% of the glomeruli are sclerosed. So this is the classification of the lupus nephritis as per ISN. Now we discuss about the treatment. So if we discuss about the treatment of the lupus nephritis, basically we are supposed to give the general treatment, and we are supposed to give the treatment as per class of the disease. And when we talk about, and beside this, we are supposed to give the maintenance treatment. So when we talk about the general treatment, we are supposed to give the RAS inhibition for the all patients. If the proteinuria is the more than 0.5 to 0.5 gram per gram, then we are supposed to give the RAS inhibition. We are supposed to give the RAS inhibition for the all patients. And beside this, we are supposed to give the hydrochloroquine SCQS for all patients. What is the benefit of giving the hydrochloroquine? Actually, hydrochloroquine decreases the renal activity. It decreases the renal process or renal activity, and it decreases the sensitivity. It decreases the severity. So when we talk about the hydrochloroquine, what is the benefit of this? This decreases the renal activity, and this decreases the severity. So if we talk about the class 3 or class 4 treatment, then we are supposed to decide, or we are supposed to see the index of the activity and chronicity of the disease. We are supposed to see the activity and chronicity of the disease. If we talk about the class 6, then we are supposed to go for the renal replacement therapy. If already on biopsy there is a class 6, then we are supposed to go for the renal replacement therapy. Now we come to the treatment of the class 3 and class 4. When we talk about the disease class 3 and class 4, the class 3, as we know, this is called the focal lupus nephritis, and class 4 is called the diffuse lupus nephritis. Focal lupus nephritis, when less than 50% of the glomeruli are involved. For diffuse lupus nephritis, when there is more than 50% of the glomeruli are involved. So how do we treat it? What we do usually, look, we are supposed to give the immunosuppression. And how do we give? We usually give the induction. And if we talk about the immunosuppression, then first drug is the corticosteroids. With these corticosteroids, we are supposed to give another one of the drug which are we going to discuss further. Now these corticosteroids in all patients, and beside these corticosteroids, we are supposed to give induction or immunosuppression with the drug which are we going to discuss further. Now what are the drugs? So first is the corticosteroids. Corticosteroids, we usually give IV methylprednisolone. And the dose of the methylprednisolone will be between 250 mg to 1000 mg per day into 3 days. So first of all, we are supposed to give the IV methylprednisolone. We are discussing the treatment of the class 3 and class 4 lupus nephritis. So when we talk about the class 3 and class 4 lupus nephritis, we are supposed to give the corticosteroids, and beside these corticosteroids, we are supposed to give one of the immunosuppression or one of the immunosuppressive drug, which will be discussed. Now, if we talk about the corticosteroids we are supposed to give like this. Number one, we are supposed to give the IV methylprednisolone 250 milligram to 1 gram or 1000 milligram per day into 3 days for 3 days, followed by the prednisolone 1 milligram per kilogram body weight, and it can be once a day, and we can taper it further. So this is the corticosteroids, and we are discussing the treatment of the class 3 and class 4 lupus nephritis. Now, the second drug is the cyclophosphamide. Cyclophosphamide we usually give in a high dose pattern or in a low dose pattern. So we give when we talk about the National Institute of Health cyclophosphamide, so NIH cyclophosphamide, how do we give? We usually give 0.5 to 1 gram meter square body surface area, as per meter square body surface area. So NIH cyclophosphamide we are discussing, we are supposed to give 0.5 to 1 gram per meter square of the body surface area, and it will be given every month for 6 months. It will be given every month for 6 months, followed by every 3 months for 4 doses. So every month for 6 doses, every 3 months for 4 doses, and every 6 months for 2 doses. So we are now we are going to discuss the cyclophosphamide, the high dose cyclophosphamide. How are we going to give? The NIH cyclophosphamide or high dose cyclophosphamide, we are supposed to give 0.5 to 1 gram meter square body surface area, and every month for 6 doses, every 3 months for 4 doses, and every 6 months for 2 doses. So this is the NIH cyclophosphamide. Now we discuss the low dose cyclophosphamide. How do we give the low dose cyclophosphamide? When we give the low dose of the cyclophosphamide, we are supposed to give 500 milligram every 2 weeks for 6 weeks. If we talk about the low dose cyclophosphamide, we are supposed to give 500 milligram every 2 weeks for the 6 weeks with azathioprine maintenance. So we are discussing the cyclophosphamide. In cyclophosphamide, we have discussed the high dose or NIH cyclophosphamide, and we have discussed the low dose. If we talk about the low dose cyclophosphamide, we are supposed to give the 500 milligram every 2 weeks for 6 weeks with azathioprine maintenance. Now, we can also give the oral cyclophosphamide. And oral cyclophosphamide, the dose will be 2.5 milligram per kilogram body weight. With or without MMF, we can give oral cyclophosphamide 2.5 milligram per kilogram body weight. With or without MMF, we can give. Now, another drug is the MMF. If we talk about the MMF, we usually give MMF 3 gram per day for 6 months, with or without high dose cyclophosphamide. We give the MMF, we can give the MMF 3 gram per day for 6 months with or without the high dose cyclophosphamide. Next drug is the azathioprine. When we talk about the azathioprine is option for the pregnancy. We can give the azathioprine in the patients who are pregnant. So this is the option for the pregnant patients. For the pregnant ladies, we can give the azathioprine beside the cyclophosphamide or corticosteroids. Now, we can give the multi-target treatment. Also. And if we discuss about the multi-target treatment, we can give the corticosteroids plus tacrolimus plus MMF, and this is superior to the corticosteroids plus MMF. So, if we talk about the multi-target treatment, we can give the cyclophosphamide plus tacrolimus plus MMF, and this is superior to corticosteroids plus MMF. Cyclophosphamide at 24 weeks in class 5 of the lupus nephritis. If there is a class 5 of the lupus nephritis, we can give the cyclophosphamide at every 24 weeks. So this is about the multi target therapy. Now in last we come to the last drug in respect to the lupus nephritis, and that is the rituximab. If we talk about the rituximab is the 2 gram, and we are supposed to give the total dose of the 2 gram and 1 gram in 2 doses and 2 weeks apart. 1 gram in 2 weeks apart we are supposed to give the rituximab, and this induces a remission in refractory cases of the disease. So in refractory cases of the disease we are supposed to give the rituximab, and rituximab induces the remission in refractory disease. So we have discussed the general treatment of the disease, we have discussed the treatment of the class 3 and class 4 lupus nephritis, and in class 3 class 4 lupus nephritis we are supposed to give the corticosteroids for the all patients plus one of the drugs which have discussed one by one. Now we come to the maintenance therapy. We come to the maintenance therapy. How do we maintain the class 3 and class 4 lupus nephritis? If we talk about the maintenance of the class 3 and class 4, the main our drug is the corticosteroids, prednisolone, less than 10 milligram per day we are supposed to give. And with the corticosteroids we are supposed to give one of the drug like MMF or azathioprine or cyclophosphamide we are supposed to give. And if we want to give the MMF, the dose will be the 2 gram per day, and if we want to give the azathioprine, the dose will be the 2 milligram per kilogram per day, and if we want to give the cyclophosphamide, the dose usually oral dose is the 2.5 milligram per kilogram per day, but usually cyclophosphamide is not recommended because overall mortality increases with the cyclophosphamide. So we can give either MMF or we can give the azathioprine with the corticosteroids. So this is the maintenance therapy of the class 3 and class 4. Now, after completion of the treatment and maintenance of the lupus nephritis, especially the class 3 and class 4 lupus nephritis, we are supposed to discuss about the class 5 lupus nephritis. Class 5 lupus nephritis, we are supposed to give the corticosteroids. And we are not supposed to give the corticosteroids as a monotherapy. Beside the corticosteroids, we are supposed to give one of the drug, and we can give the MMF, and MMF usually we are supposed to give with high dose cyclophosphamide or without the high dose cyclophosphamide or NIH cyclophosphamide. So one is the MMF. We are supposed to give the MMF with cyclophosphamide or without cyclophosphamide. Now the cyclophosphamide we are supposed to give the low dose of the cyclophosphamide is usually preferred. We can also give the high dose cyclophosphamide, but low dose of the cyclophosphamide is the preferred. The other drug may be given for the class 5 lupus nephritis. These are the calcineurin inhibitors. Calcineurin inhibitor usually the remission is 83% versus high dose cyclophosphamide. That is the 60% in class 5 lupus nephritis. If we talk about the remission of the class 5 lupus nephritis, and we do the comparison between the calcineurin inhibitor and the cyclophosphamide, the remission is 83% in the calcineurin inhibitor and 60% in the cyclophosphamide. And with the cyclophosphamide of class 5 lupus nephritis, the relapse is very much common. So this is the about the calcineurin inhibitor. Another choice for the class 5 lupus nephritis is the rituximab. So we can also give the rituximab in case of refractory lupus nephritis, or in class 5 lupus nephritis we can give the rituximab. So this finishes the treatment and this finishes the lupus nephritis.